introduce myself again, Tony Aldave. And my topic, if I got my slides up, is related to something that you just heard discussed, the LAL and its potential utility at the time of combined endothelial keratoplasty and cartilage extraction. By way of disclosure, I have no financial interests relevant to this presentation. So I want to present to you a patient who I saw. This is a recent case, 67-year-old woman who presented with slowly progressive decrease in vision in her left eye for the last several years. She'd had LASIK performed in each eye in the late 1990s, dry eye syndrome, Fuchs dystrophy diagnosed a couple of years ago, and nucleosclerotic cataract in each eye. On exam, vision in the right eye was not bad at 20/25, but fairly poor vision in the left eye at 21/25. You see her refractive error listed there. See also the central corneal thickness, a fairly edematous cornea in the left eye. In the right eye, on slow examination, 1+ central stromal edema and 1 to 2+ nuclear sclerotic cataract. Left eye looks similar with a LASIK flap, but she had central epithelial edema in the left eye. That was probably the reason why her vision was so poor. A little bit more stromal edema, and again, a 1 to 2+ nuclear sclerotic cataract. So I did tomography for this patient. This is the right eye. Again, she's had prior LASIK surgery. You see her mean K value is 44.0. In the left eye, the mean K is fairly similar at 43.6, but you can see on the axial map a very irregular cornea with a focus of scarring or flattening, something here, and relative steepening superiorly. So a fairly irregular cornea, although the mean keratometry value is fairly similar to that in the contralateral eye. So what do you do when you have a patient for whom you're going to want to perform endothelial keratoplasty, either DMEK or DSEK, plus cataract surgery, who has epithelial edema in the operative eye that prevents you from getting accurate keratometry? You can either say, well, yeah, like in this case, the K value is about the same as the other eyes, so I'm just going to use it, even though that's a two-toned cornea. You can, if you're smart, go back to keratometry that was performed prior to the onset of epithelial edema, and every time I see a patient with Fuchs in my practice, we always get baseline tomography, so I'll know what their Ks are if they do develop epithelial edema in the future. You can do a debridement and then measure, and we've done a small study looking at keratometry values post-DMEK compared to doing keratometry on exposed Bowman's layer, and it's, as you would guess, about the same, not a big difference. Or you can use K values from the contralateral eye. So these are your options in this situation. Again, remember, this patient's had prior LASIK surgery, so you also need to account for that. Everybody has their preferred formulas or techniques for adjusting IOL power calcs in patients with prior refractive surgery. In this case, I usually use the ASCRS post-refractive IOL calculator and the Barrett TrueK, which is in the ASCRS, but I also use it separately as well. So the calcs, as you see here, that came up for we're using the ASCRS post-refractive IOL calculator range between about 19.6 and 22, depending whether I'm using Ks from the right or the left eye. The Barrett TrueK formulas between 21 and 22, again, depending on whether I'm using Ks from the right or left eye. And if I just ignore the fact she's had prior cataractive surgery, just use IOL master calcs, you see between 20.5 and 21. So I decided to sort of split the difference between the highs and lows, the range from the ASRS calculator as well as the Barrett TrueK, and went with the 21.5. So I performed surgery for her in May of last year, put in SN60 WS plus WF plus 21.5. Surgery went fine, but you'll note that 3 months after surgery, the patient was not happy with her uncorrected vision. She corrects to 20/40, but with about plus 2.5 diopters spherical equivalent refractive error. Checked her again a couple months later. Now she corrected down to 20/25, but now with over 3 diopters of hyperopic refractive error. Again, not my happiest patient. And then in January of this year, she corrects finally to 20/20, but with a spherical equivalent refractive error of more than +2. And again, I aim for -1. So we had a greater than 3 diopter hyperopic surprise. Why is that? I went back and checked all my calculations. They were done correctly. Well, here's the patient's left eye. This is in October, so we are here about 5 months post-op. You can see that that mean K value is 40.0. Remember, pre-op, it was 43.6. The other eye was 44. So this eye is 4 diopters flatter than the contralateral eye. I said, well, it's going to hopefully steepen over time. It did a tiny bit, but only to 40.6. So here the problem is, and you can see on the axial map, we have a much flatter cornea, and due probably to the subtle subepithelial scarring that she has that was a result of the epithelial edema. I looked very carefully pre-op, I always do for subepithelial scarring, but you guys know if the pachymetry is 800 and something and you have epithelial edema, it's very hard to determine if there's any subepithelial scarring there, and if so, how much. So how common is this? This paper from Frank Price's group looked at DMEK and cataract surgery with implantation of a monofocal IOL, and they found that only 30% of patients were within half a diopter of the targeted refractive error, and only 50% were within 1 diopter of the targeted refractive error. And I think as a lot of us are doing more and more DMEK, we're expecting better and better visual outcomes, that this has become one of the major problems in my practice, is these unexpected refractive surprises after combined DMEK and cataract surgery. And is there some other way to address this problem? Well, per the last discussion we had after the last presentation, yes, one approach is the light adjustable lens. And I think many of you are familiar with this lens. This is a lens that is implanted. You see a 3-piece lens. It's then exposed to ultraviolet light in a pattern such that induces a change in the shape of the lens to correct for a refractive error that is present, as far as corrects both hyperopia and myopia, and as Audrey said, I think up to 3 diopters of cylinder. Once that lens shape is what is desired, is then quote-unquote locked in so that the shape is stable. And this is, I think, something that could be of great utility to us as corneal surgeons, keeping in mind, though, that we don't really know the final refractive error after DMEK until you're at least 2 or 3 months post-op. And if you do this combined with penetrating keratoplasty or DALK, you're going to have to wait many, many more months. And so there are some adaptations to the lens that allow for delayed locking in. And Audrey can talk to us about the lenses that patients wear, UV protection to prevent environmental lock-in before it's time. This is the machine. We have this at Stein Eye Institute, and I do not have any experience yet. But after putting this talk together, I decided this is something I'm going to start doing routinely for my DMEK cataract patients who can afford this option. The question is, though, does it improve outcomes? Is this a theoretical advantage, or is there actually any evidence to say that this does improve refractive outcomes? Marianne Price kindly shared this article with me, which is in this month's JCRS, just published, where they looked at Frank's series of patients with DMEK cataract surgery with the light adjustable lens. In 27 eyes, we see that 81% were within a half a diopter of the targeted refractive error. Remember, their prior publication, same surgeon, with a monofocal lens was 30%. And they have 93% within 1 diopter. Again, with the prior series, it was only 50%. So pretty impressive. Also, if you look at refractive cylinder accuracy, they're reporting 93% within a half a diopter of the targeted correction, and 96% within 1 diopter. So again, it's not the biggest series, but I think big enough to convince me that this is something which can be of great utility in some of our patients. So while cataract extraction is commonly performed at the time of DMEK and DSEK, accuracy of the calculations can be affected by a number of different factors. This patient had a couple of them: prior refractive surgery and corneal epithelial edema, as well as subepithelial scarring, which I didn't appreciate really pre-op. Also, even if the patient doesn't have epithelial edema, we all know that patients with Fuchs, for example, have typically central edema, stromal edema, that can cause a contour change. And once that edema resolves, then the cornea then becomes flatter. So I think that's one of the common sources of error in IOL calcs in patients undergoing DMEK cataract surgery with Fuchs. So the accuracy of refractive outcomes in patients with corneal edema can be improved. You can do DMEK or DSEK prior to cataract surgery, and I've done this a few times. I know some surgeons do this fairly routinely. In the setting of corneal epithelial edema, using K values obtained prior to the onset of epithelial edema, again, that's useful if they don't have subepithelial scarring, but if they do develop subepithelial scarring, those prior K values are not going to be that useful. You can do a debridement. If I do a debridement, I like to usually do it the day of the surgery, because if you do it a day prior or a few days prior, you're going to have increased edema, of course. If you do it maybe a week prior, patients are not going to be happy with the discomfort, so usually do it day of if I do. or you can use the case from the contralateral eye, but I think the LAL, the light adjustable lens, offers a potential great option for these patients. And I thank you very much for your attention. Any questions or experience with the LAL from those in the audience?
Tony, I agree. I really like the LAL in this situation. I just started to do them for DMEK, and it works very, very well, just for all of the reasons that you delineated. I wouldn't necessarily recommend it for PK, but in the DMEK and DSEK series, you have to be sure that the patient understands that there's going to be several light adjustments. It is a little bit labor intensive, the post-op, but I actually have my optometrist doing the light adjustments, and that's a big time saver because it's sort of like, it's several visits, 3 to 5 visits, or actually 4 to 6 visits post-operatively. You've got 4 shots on goal to be able to correct the lens, usually within 2 light treatments. It's where you want to be, and then there's 2 small lock-ins. But yeah, I completely agree.
The question I have, and this is a silly question, but I think, you said, what's your second biggest issue you face with doing DMEK cataract surgery? For me, it's IOLs that want to prolapse out of the bag while I'm trying to insert my DMEK graft. That's still, even if I have a decent-sized rexus, say 4.5, and it's centered, I still have trouble sometimes getting that DMEK scroll in. So do you have any thoughts about whether this 3-piece design versus the typical 1-piece that we use, does that make the IOL tend to prolapse more, less, or does not seem to make a difference when you're inserting your DMEK scroll?
I haven't found that it's been a real issue. I also use a femto laser for my capsulotomy in these cases and when I'm doing my LALs. And
Yeah.
I find that that's also very helpful for getting it spot on. I do make it a little bit smaller.
How big?
I do about I program the laser for 4.8, and so I get about a 5 there. And I find that the lenses center really well. You have to be careful about your capsular polishing because you can get early fibrosis and need to do an earlier YAG with the lasers. But I mean, with the LALs, it's not that big a deal, but it's nice if you don't have to do it. I did have one case where the patient was having some discomfort, a wiggly patient, and so I didn't polish as I normally do, and she ended up with some fibrosis there early. The lens actually shifted a little bit, and I had to go, what I did is I went back in and then I prolapsed the optic out of the bag. The nice thing is that it's a 3-piece lens, so you can also use it. I've also used it for unhappy patients after a multifocal or EDOF lens. I've done an IOL exchange for the LAL, and you can put it in the sulcus with optic capture, and that works well too.
Huh. Points, thank you. Sunal?
Great talk, Tony, as always. Two questions. One is actually with the prolapse. Do you constrict the pupil before you put the?
Always.
Okay, and it still prolapses out because my.
Well, it doesn't prolapse out. It's just you get positive pressure. I just find that, sometimes pupils don't come down. Sometimes they kind of halfway come down. But even with a lens in the bag, centered, good rexus, pupil constricted to 4, let's say, I still find on some eyes I'm trying to insert the DMEK scroll, maybe 1 out of 4, and just chamber just keeps shallowing.
Yeah.
And the incision's not leaking. It's just the lens is not fibrosed in the bag, and I find that to be.
It is definitely much more floppy, right?
Yeah, and in fact, when I'm teaching fellows and I teach DMEK internationally, I usually tell them don't do DMEK cataracts until you've done at least 20 DMEK. Do your cataract surgery first and go back and do your DMEK a month or 2 later once the lens is fibrosed in the bag a bit, so you don't have to deal with that tendency for the chamber to shallow where you're trying to insert the DMEK scroll.
So my question actually was that, percentage-wise, how many would you say you do together versus do the DMEK first and then do the IOL after, or do the cataract first and then the DMEK later? And in relation to that, how comfortable are you putting a multifocal lens in these patients?
I'd say if I know the patient's going to need DMEK and cataract surgery, 95% are combined.
Mine are too, so okay.
If the view is just really bad, I may do, and they need cataract surgery, I'll do the DMEK first, then cataract later. Obviously, we have these patients with mild corneal edema where I try to get away with the cataract surgery first, and then DMEK later if necessary. But in those, I know we're going to need both. It's almost always combined or rarely DMEK first. Multifocal, I haven't.
Okay,
I
I
haven't
haven't either.
had-
I'm just curious to
Yeah,
know.
I'm just not sure about the optics. I'm sure many do that, especially in Los Angeles. But I've seen a fair number of unhappy multifocal patients who have Fuchs or had DMEK from other places, and I just don't want to have an unhappy patient with a well-done surgery. John.
Tony, great talk. The prolapse issue is the insertion technique. If you do endo in, you won't get that. Because Divya asked me when she came to Singapore, how many cases do you do mixed? And I do all my combined cases, but I've never had that issue because the AC is completely deep when we pull the graft in. It's a technique issue because when you're doing endo out, you're shallowing the AC, and that's why in those cases, so obviously we get a lot of pseudophakic cases sent to us. And I'm very careful in those cases because you know if you shallow the AC, vitreous is going to come from somewhere because obviously you don't know who's done the cataract surgery, right? And by definition, it must have been difficult because they've got pseudophakic bullous keratopathy. But with endo in, you avoid all that situation because you're not shallowing.
And the technique you're using is a forceps-assisted insertion?
Exactly. So Divya's video that she basically showed you.
That was showed yesterday?
Yeah, so basically
Okay.
just endo in, obviously we use the EndoGlide 27 gauge forceps and pull it in. You'll never get that because your AC is going to be super deep when you
Right.
basically pull it in. So you avoid all these issues of shallowing. And when I switched techniques about 7 years ago, I noticed a few cases, sometimes, especially with thick irises, sometimes you see a little bit of pigment release when I was tapping to open the graft, and I just never see that now. And it was just a technique change.
Huh. And probably less CME as well, if you're having less shallowing and less iris manipulation. That's been an issue
Yeah.
for me.
Yeah, we discussed some of this stuff that we wanted to discuss, but that's great. You know, one thing about LALs in that paper from Frank, would you guys think that it'll probably, if I have to do an LAL at least for the first 20 cases, I'll probably not do a triple and do a staged procedure. So you figure out, the graft is okay, 3 months later you can do an LAL. Or you'd rather prefer a triple if you're doing an LAL. I don't know how difficult the adjustments are. If you have 4 shots at adjusting the lens power, when do you start adjusting the lens power, Audrey? Yeah.
You can start as early as 2.5 weeks, but with DMEK, following a DMEK, I actually wait a full 6 weeks.
6 weeks.
6 to 8 weeks, and I let them know that they're going to have to wear their glasses for 6 to 8 weeks before doing the first adjustment. Normally, if you have a LAL, you can do 2.5 to 3 weeks. If things look stable, you can start the first adjustment then, and then the second one about a week later. Then you can lock in about a week after that, or whenever you want, if it's fine. But with a DMEK situation, I wait a full 6 to 8 weeks because you want it to be more stable. You don't want to do it at 2 to 3 weeks.
So I think that's important as well, the difference.